Welcome to the Journal of Precision Oncology interview series, where we speak with the physicians and investigators behind remarkable papers that are shaping cancer research and patient care. Today, we are discussing the recent publication, Lessons from Exceptional Responders with High-Grade Brain Tumors Treated with Precision Targeted Therapies, a paper that highlights how biomarker-matched therapies were successfully utilized in patients with aggressive high-grade brain tumors. To explore the profound clinical implications of this work, I'm honored to be joined by a truly outstanding panel of experts. Dr. Kursrock, Director of the Center for Precision Oncology and Rare Cancer at the Medical College of Wisconsin, Dr. Disel, Associated Professor of Medical Oncology at the Acıbadem Hospitals Group in Turkey, Dr. Ulalia, Deputy Director of the Miami Cancer Institute, and Dr. Srinivas, Assistant Professor of Medical Oncology at the City of Hope Comprehensive Cancer Center. Thank you all for being here, and thank you for the opportunity to discuss such an important paper for the brain cancer community. Your paper highlights how customized biomarker-matched targeted therapy can result in exceptional multi-year remissions in high-grade gliomas, a disease where standard of care treatments typically yield median overall survival of just about 14 to 16 months. Starting with Dr. Kursrock, in the introduction of your paper, you draw a powerful parallel between these high-grade glioma cases and early exceptional responders in gastrointestinal stromal tumors treated with imatinib, which ultimately transformed the disease treatment paradigm, as we know. How crucial is for you the continued study of these rare outliers in catalyzing a similar paradigm shift of little brain tumors, which, as we know, have historically lagged behind in precision oncology?
Well, thank you for the question, and I think this is an extremely important question. So I think these patients are outliers, not just because they're exceptional responders, but especially because of the way we treated them. And I believe that's what made them into exceptional responders. And the parallel with GIST, I think, is a very appropriate parallel. I don't know if everybody remembers at this point, but GIST was considered one of the worst cancers. It was completely untreatable. The response rate to chemotherapy approached 0. So analogous to GBM, actually maybe even worse, were very difficult tumors. And the whole GIST landscape was changed by a single case report in New England Journal of Medicine, where imatinib was given to a patient with a GIST and a KIT alteration. And this patient had an exceptional response. And this now opened the doors to really transform GIST. So GIST is now a very highly treatable, tumor with imatinib and other KIT targeting agents and other agents. And I can only hope that we begin to similarly open the door for a precision approach to glioblastoma.
Thank you very much, Dr. Kursrock. Indeed, it shows how we can translate findings from one disease to the other, and kind of changing the paradigm of how we manage these tumors. Dr. Disel, looking at the clinical management of these patients, as the lead clinical investigator managing these patients, you navigated a clearly complex clinical landscape. What were for you the practical day-to-day challenges of implementing a comprehensive next-generation sequencing and successfully acquiring multiple off-label target therapies such as everolimus and imatinib for a rapidly progressing glioblastoma patient population?
Yeah, thank you very much to give me opportunity to respond to your question. And I think that is very important and very practical question, because one of the biggest real-world challenge was not only identifying actionable targets, but also gaining timely access to off-label targeted therapies for these rapidly progressive patients and disease. I think in daily practice, the biggest challenge was really timing. and high-grade glioma and GBM patients can progress very quickly, and so comprehensive genomic profiling had to be performed early enough to results to remain actionable. Yeah, it was not just about ordering NGS, but about getting clinically meaningful results back fast enough to guide treatment while the patient was still fit enough to benefit. I think the second challenge was the interpretation of the results. Not every molecular alteration is truly actionable, so we had to decide which finding was most biologically relevant and which drug could realistically be matched to it. In our series, that meant linking therapies such as imatinib, everolimus, or ivosidenib to specific genomic alterations. And of course, getting access to these treatments was itself a major challenge. Even when we had a strong biomarker-based rationale, obtaining off-label targeted therapies required considerable logistical and regulatory efforts, and all while managing neurologically fragile patients. So I think the key lesson is that, especially in glial tumors, we need to bring molecular actionability and biomarker-guided therapy into clinical practice much earlier rather than reserving them to final stage of treatment. As Rezel Körzrak, our professor and mentor, has emphasized for years, precision oncology only works if we implement it early enough to act on it. And when we do, selected patients may achieve truly exceptional and durable response. Thank you.
So thank you so much for highlighting how key is to first early identifying these patients and having in place a framework that allows us to access drugs on a timely manner. Dr. Srinivas, looking on the background of how important it is for us to truly understand the main drivers of this disease, I would like to dive a bit deeper in the functional hierarchy of these genomic findings. Looking at the precise case, the case 4 of your paper, where we saw an exceptional 48-month response to everolimus in a recurrent GBM that was harboring a PTEN frame shift and a homozygous TSS2 deletion. In early phase precision oncology, we frequently battle the redundancy and adaptive molecular feedback loops, particularly within this PA3K, AKT, and mTOR axis. When you are looking at this really complex NGS reports, how do you determine the true driver of these tumors, and how would you select which driver to target, and how it won't be like simply bypassed by an alternate pathway or an alternate cascade? Can you walk us through your process?
Thank you, Diogo. Excellent question. So when making a decision on which driver to select, we go by existing data. So we look back, do literature search, and figure out where associations are there, like what type of driver mutations have already been described as specific disease pathology. We look at drug options, we look at tolerability. So essentially personalize precision medicine for these patients. Now, I also specifically focus on, so here your case 4, if you look at PTEN loss and TSC2 deletions, both TSC and PTEN are tumor suppressors, right? So if there is deletion there, if you look at the tuberous sclerosis complex, they ultimately lead to activation of mTORC1. So essentially a same larger nodal pathway being involved here. So if there are convergent pathways, and as has been shown in prior studies, that if you focus on convergent pathways, that there are mutations that kind of affect the same pathway, I would focus on that, and I would certainly take the disease into consideration. Now, the issue of alternative pathways, resistant mutations developing is real, and there's always a problem. But as Dr. Körzrak and Dr. Caro and others who have participated, and Dr. Körzrak has championed the iPredict studies, the more pathways or viable pathways you target, the better it is, provided you use the drug combination in a safe manner, and accounting for some of these pathway alterations that may develop later, and also realistically following these in real time, following these patients for resistant mutations developing, and then again intervening in actual time. So these are some processes that happen in real time, and we have to make changes in real time if we do see certain alterations occurring that would cause resistant mutations. But trying to focus on a larger nodal pathway is what I would do to decide which therapies I would start with.
Thank you so much for your insight. It really helps us to understand how these decisions are made in real time and the real application of this process of thought when we're discussing patients on our multidisciplinary tumor boards. Dr. Hulalia, as a leading neuro-oncologist, we have facing the field not being able to move the needle past the 14 to 16 month median survival for GBM. And looking at this paper, we saw a multi-year remission in this case series using agents like, as we discussed, everolimus or ivosidenib. For you, what are the primary neurological challenge, such as central nervous system penetrance or even the blood-brain barrier, that we must address when we think about designing trials or pairing these patients to target therapies to have the most successful clinical approach when treating these patients?
Yeah, sure. So definitely, I mean, it was such a great experience working with this exceptional team being led by Dr. Kazrak, looking at this compilation of exceptional responders. And I would just reiterate the point that, we can have exceptional responders in brain tumors too, as exemplified with these case series. What I would state is, as a medical neuro-oncologist taking care of these patients, we do face a number of challenges as we treat patients with high-grade gliomas or glioblastoma. And one additional challenge that we face is the blood-brain barrier issue, right? It's one of the most fundamental challenge and created by tight junctions between the cerebral endothelial cells, and then that combined with flux pumps prevent a lot of systemic agents from getting in, and if they do get in, a lot of them get pumped out. So I think picking the right drug with penetration is critical if you have multiple targets or multiple drugs rather in this case. It's important, and a great example of that is the newer agents which are being developed for brain metastases. We have drugs like lorlatinib, which are not only great drugs with target, but also have exceptional blood-brain barrier penetration. So osimertinib in EGFR was pretty transformative for EGFR patients with brain metastases with lung cancer. Similarly, now lorlatinib, and we are seeing that phenomenally, at least in the field of brain metastases, where now the new drug development does take into account penetrance of the drugs, especially when drugs are being developed for common cancers like lung cancer and breast cancer that tend to go to a brain, similarly for melanoma. I think high-grade gliomas can certainly follow suit. One additional perspective that I would like to share with the audience, which may not be very well known, but could be very interesting, that will be changing paradigm for patients with high-grade gliomas or glioblastoma in particular, is going to be these non-invasive ways of disrupting blood-brain barrier, which is in particular using focused ultrasound. So it is basically a non-invasive way where you actually have MR-guided focused ultrasound, where you can actually disrupt the blood-brain barrier for 4 to 6 hours, and it starts resealing after 6 hours or so. And then we have shown that after 24 hours, it actually reseals. It's a great advancement. The other advantage of this approach is that because it's mechanical disruption, it actually does induce immune priming as well. Traditionally, obviously, we all know glioblastoma is one of the most immunosuppressive tumors out there, and so far the use of immune checkpoint inhibitors has not proven of any benefit to these patients. So I think we are very excited. Actually, I've been involved as a global PI on 2 trials with a blood-brain barrier system called Xablate. There's an ongoing study in lung cancer brain metastases, combining that with pembrolizumab along with chemotherapy or dual checkpoint inhibition with ipilimumab and nivolumab. And we are in the process of designing trials with antibody drug conjugates, which seem to be exciting as well with such modalities. So I think a future is bright for patients with glioblastoma, and Dr. Kazrak very eloquently alluded this case report of a patient with just being treated with imatinib, which has really transformed the field. And there are numerous such examples, with RET inhibitors and number of other agents. And I think one of the things that I would want to highlight as a neuro-oncologist is that belief that we can identify targets in patients with high-grade glioma. So it is important to do high-level molecular profiling for our patients. We send all of our patients for both robust DNA and RNA profiling. Methylation is extremely interesting as well. So one message is profile patients with high-grade gliomas, and then, as alluded to by these cases, work towards picking the right drug for the right patient. And that's the whole perspective of precision oncology. And we have with us, Dr. Kazrak, who's been one of the leaders in the field of precision oncology for solid tumors for over 2 decades. So could not be more thrilled to see the outcome of these patients, but also excited about leading this as an example to profile patients more frequently and then picking drugs for them. Because we know the standard cytotoxic chemotherapies that we have for our patients in glioblastoma don't offer a lot of benefit for these patients. But all of us have been involved in clinical trials, and although the trials are negative or have failed to reach their endpoint, and actually I was involved with a trial with everolimus, which was which did not reach its primary endpoint or was negative study, but there were a select group of patients who got benefit. And that happens with every trial. So as Dr. Kazrak alluded to, we can learn from each patient, and then picking the right patient with the right target, with the right drug, and then bringing them together is the whole gist of precision oncology.
Thank you so much for your answer, and for highlighting how important it is for us to pick the right drug for the right patient, even more on unmet need population as the GBM patients. Dr. Kazrak, just to try and close our discussion and picking up on the relevance of picking the right drug and trying to bridge to your broader work. You were leading the landmark High-Project study where you used the N of 1 study design to look at multi-drug regimens in an individualized fashion to maximize the matching score for complex solid tumors. In this work, you proved that the novel drug combinations, when adequately titrated to individual tolerance, actually resulted in fewer toxicities and in improvements in progression-free and overall survival. Given this proof of concept, how would you design a prospective N of 1 clinical trial specifically dedicated to glioblastoma? Moreover, what specific trial design modifications do you think are needed to adequate the unique specificities of this patient population, meaning the blood-brain barrier that we have just discussed, the concomitant use of steroids that most of these patients have, and of course, the timing, because we are talking about a patient population that rapidly, unfortunately, has a clinical deterioration. Could you please give us your opinion and your views on this?
So my opinion is that we need a glioblastoma trial that is very similar to iPredict, and that as early as possible in the disease, and I'm going to get to the as early as possible in a minute, the patient should be profiled, and then as many alterations as possible be targeted. And it turns out that GBM patients do have alterations that we have drugs for. Not all the alterations, but they commonly have, for instance, EGFR alterations or cyclin alterations and other similar alterations that can be targeted. So I think it is essential to have a trial that for GBM that individualizes the therapy, gives more than one drug, because we already know that for many advanced cancers, and GBM is a very aggressive cancer, giving one drug at a time is suboptimal. But giving a combination of drugs that is matched to each of the alterations optimizes the response. Now, historically, we were afraid to give such customized combinations. And we felt that we had to do a phase 1 trial before we gave any new combination. That is clearly a legacy of the cytotoxic era, where cytotoxics in combination, there was a lot of concern about excess toxicity. But in the new era of targeted therapies and immunotherapies, what we showed with our iPredict publications is that we can safely give these combinations by simply reducing the initial dose and then titrating the dose to each patient's tolerance. And that reducing the initial dose, unlike with chemotherapy, did not compromise the response, but it allowed us to give first-in-human regimens, multiple first-in-human regimens, safely. So I think this is absolutely ripe for a GBM-focused trial. And again, many of the alterations in GBMs we do have drugs for. We just need to apply them and not apply them one at a time, but to apply them in combination and to treat each individual as an N of 1. Giving each individual their own customized combination of therapies.
Thank you so much, Dr. Korsrock. Just to finish, do you see any role for longitudinal monitoring on these patients using cell-free DNA on the cerebrospinal fluid to monitor, as you were explaining to us, these dynamic changes on the drivers and the surge of new resistance mutations or new changes that can drive progression, and how this could be incorporated on this N of 1 trial design? Can we have your view on this?
So that's a really important question. I'm going to make a comment, but I'd also like Dr. Alawali perhaps to comment. So one of the issues we were really disappointed with was blood monitoring. So we use ctDNA monitoring in blood all the time for many tumors. But when we looked at our glioblastoma patients and we looked at the blood, we a couple of years ago published a paper on this. Almost all the alterations turned out to be CHIP, clonal hematopoiesis of indeterminate potential in glioblastoma. I don't know if it's because they've received radiation or temozolomide, but even in young patients, we found that the alterations were CHIP. So the current technology we have with blood ctDNA monitoring that is really good for other advanced tumors, I think is not adequate for brain tumors. So that brings up the issue of CSF monitoring. And we have not had a good assay that is clinical grade to do CSF monitoring, but I think it's a very attractive idea. And I would like Dr. Alawalia to comment on where the field is with CSF monitoring.
Yeah, sure. No, absolutely. And I think, so spot on that we do will encounter challenges with CHIP, and some of it is just, GBM cells really divide rapidly, and there's replication stress, DNA damage, could be substrate for chromosomal rearrangements. I think there are platforms which have now gotten better in the last few years. Caris Life Sciences has a platform where they are able to distinguish between that and their new algorithms. What I would share again first on blood, and then I'll go to the CSF. So on blood, I think one exciting aspect, the same MR-guided ultrasound that actually non-invasively disrupts the blood-brain barrier. We actually had a study. I actually served as the global PI. We are analyzing the data, so should be available soon. So we actually have been in talks with FDA to see if that increases the yield of cell-free DNA. And basically what it entails is getting a blood sample before for plasma and checking the cell-free DNA, We are doing a bunch of other analytes as well. And then we actually do the procedure and then collect blood actually at 30 minutes, 1 hour, 2 hours, and 3 hours on the protocol. And we have 50 patients. And then we actually had to take those patients to surgery to show a concordance between the tissue and the blood. So hopefully in the next few months, we may at least have some additional possibilities there. What I would say as the CSF question, so there has been work that has been shown by the MSKCC group that if they are posterior fossa tumors or tumors which are close to the ventricles, you have a bigger yield with the CSF even compared to tumors which are more, frontal or others. But to Dr. Kurzrock's point, no one really has independently validated CSF platforms. A lot of companies are now looking at it as we are getting better with therapeutics because people would love to know it. And so there are some companies which have offered services. A lot of the work has been done in blood, but there are a couple of providers which are very closely looking at it in the CSF, and one such company is actually Belay, which spun out of work coming out of Johns Hopkins. Chetan Bedagada, who's the chair of neurosurgery at Johns Hopkins, actually has done a fair amount of work in this. And we have been using that platform more recently for a lot of leptomeningeal perspective, where we, not only want to monitor these patients, but it is also used for targeted identification. So I think this field will really open up significantly. I still believe, CSF is a preferred place to go, slightly more invasive than getting a blood sample. But depending on how or the differences that we see in the blood, blood-brain barrier disruption study that we are doing, we may have additional avenues to increasing the yield. So, and even to Dr. Kurzrock's point, the first several studies that were done initially, the yield in the blood has not been that great to recommend this routinely for our patients. CSF, yes, you can if you have the right platform, but I think blood may become an interesting story post results of our study. So stay tuned. We are excited about it because, again, just reiterating the point, we think, we are definitely at this cusp. We are now going to probably have new drugs for pancreatic cancer. And, so I would always look at my colleagues, other solid tumor colleagues, which had, tumors with dismal outcomes. And now we might just have this inflection of drugs coming for pancreatic cancer. And I think glioblastoma is right behind them, just picking the right drug, right patient, as we use these more, innovations, not only in just drugs, but drug delivery, which will help our patients.
Thank you so much. I think that we reached the end of our discussion. Thank you so much all for sharing these invaluable insights regarding the importance of precision medicine and precision cancer care for all solid tumors, but indeed for glioblastoma and high-grade brain cancers. And it's clear that this case challenge the historical status quo for these high-grade brain tumors, and they highlight how comprehensive genomic profiling and customized treatment strategies can indeed impact the clinical outcome and change the treatment paradigm. So once again, thank you very much for your time, and I hope that everyone goes and reads this outstanding paper. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.